Welcome to the Reproductive Health track on day one of the APJ Genetic Solution Tour 2020. My name is Michael Richardson, and I will be your moderator for this session. During this session, we will focus on the use of next-generation sequencing technology for expanded carrier screening applications, pre-implantation genetic testing for aneuploidies, as well as monogenic disorders. As a reminder, if you have any questions for our speakers, please submit them in the Q&A box, and our speaker will address your questions following the presentation. Our first speaker today is Dr. Mohamed Saleem, the Laboratory Director at GenomixLAB in Malaysia. Dr. Saleem received his PhD in medical genetics from the University Putra Malaysia in 2011 and undertook a postdoctoral fellowship working on acute myeloid leukemia and pharmacogenomics at the University Sains Malaysia. Dr. Saleem has been working in the field of genetic diagnostics since 2011, and in 2016 he joined GenomixLAB as the laboratory director. GenomixLAB is a private molecular diagnostics company providing genetic testing services that specialize in reproductive genetics and cancer genetic testing. Today, Dr. Saleem will be sharing with us his experience with expanded carrier screening, and he will be providing an overview about bringing expanded carrier screening in-house using next-generation sequencing technology. I welcome Dr. Saleem to give his presentation.
Thank you very much. So what I would like to do today is to share our experience using expanded carrier screening assay at GenomixLAB. This is my disclosure slide. So at GenomixLAB, our main area of services are in the domains of reproductive genetics and cancer genetic testing. Under the reproductive genetic testing domain, we offer multiple small carrier screening panels for reproductive partners to screen them for autosomal recessive disorders. Carrier screening at GenomixLAB is mainly aimed at identifying couples who are at increased risk of having an affected child in order to facilitate informed reproductive decision making. In the past, we offered targeted carrier screening, and we use many different approaches like allele-specific PCR for point mutations, gap PCR for large deletions in alpha-globin gene, for example, small NGS panels, and a series of MLPA reactions for copy number changes. As many would agree, there are multiple challenges in these panels, especially custom-made panels, as it only addresses to some handful of common autosomal recessive disorders in the local population. It does not screen for rare genetic changes and mostly designed for hotspot testing. It is also laborious to perform multiple protocols, and since our populations are made up of many subpopulations, these small panels are not fit for all ethnic groups and that make up a population. So we need an expanded carrier screening approach to serve these couples better in understanding their risk of having an affected child when they are planning a family. Having said that, in spite of these smaller panels that we use, using multiple approaches of carrier genetic testing, we at GenomixLAB observed that about 48% of individuals tested for carrier screening are carriers for at least one autosomal recessive condition. And out of them, about 4.5% of the couples are carriers for mutations on the same gene. So when a couple has got the same mutation on a different or a different variant on the same gene, there will be about 25% risk that each pregnancy would be affected with either homozygous or compound heterozygous offspring. So our main aim would be to reduce this unfortunate event for these couples and inform these couples of their risks ahead of the planned pregnancy, counsel them appropriately, and provide them with reproductive options so that the couples can make better informed decisions planning a healthy family. So the general approach for the couples in this category with a mutation would be to offer PGT-M for them, after genetic counseling. Now, the numbers presented here may change if an expanded carrier screening was offered to our couples, and may add on extra prevention for more couples to prevent birth of affected children in their families. So our lab had early access to expanded carrier screening panel called CarrierSeq from Thermo Fisher Scientific. We have already analyzed about 80 samples using this panel, and it gives us very promising results. This AmpliSeq-based panel combines many standalone tests into a single assay that contains 420 genes covering entire coding regions, including about 25 base pair into the flanking intron exon boundaries. The panel is designed to detect at least more than 28,000 non-benign ClinVar variants, including both single nucleotide variants and copy number changes. Unlike many other expanded carrier sequencing panel, unlike many other expanded carrier sequencing panels out in the market, this CarrierSeq panel include difficult to sequence genes due to pseudogenes and homology between paralogs, such as SMN1 for spinal muscular atrophy, and HbA1 and HbA2 for alpha thalassemia, GBA for Gaucher disease, CYP21A2 for 21-hydroxylase deficient congenital adrenal hyperplasia. This ready-to-implement workflow contains optimized reagents and customizable CarrierSeq reporter software for data analysis and reporting. So we find that this is a very useful product for reproductive genetic testing in our lab. So the integration of CarrierSeq workflow in our lab was seamlessly easy. Those labs using AmpliSeq workflow will find it easy too, especially if your lab is doing whole exome sequencing library prep, because both are very similar in the wet library preparation. So this slide shows the steps involved in AmpliSeq carrier screening workflow and the expected time we spent in each stage. The beauty of this product starts at the library prep because you will be preparing a single library for both single nucleotide variants and copy number changes. And therefore, it is extremely appealing because otherwise we will be doing a series of MLPA reactions that require overnight hybridization and multiple PCR reactions for different other mutation testing, and also involves more than one staff to handle these procedures. But with the introduction of CarrierSeq workflow in our lab, it has changed the way we approach carrier screening for couple testing. So we start the library prep in the morning, and by the end of our 8-hour shift, the libraries are ready for automated overnight template preparation. That includes isotomal amplification, enrichment of the iron sphere particles, and chip loading. So this will take about 13 to 14 hours, including the hands-on time. So the next morning when you come for work, the chips are loaded and ready for sequencing. And with the use of Iron S5 system, the sequencing is completed within about 2 hours, 45 minutes per chip, and data is ready within about 6 to 8 hours after the sequencing of the chip. So all in all, the entire process from library prep to reporting will take about 2.5 to 3 days in total. So this slide shows some run QC metrics from a typical CarrierSeq run on an S5 sequencer. The total number of bases is 16.6 G with an ISP loading of 87%. This particular run has achieved over 88 million reads, which is more than a theoretical maximum for a 540 chip in general. and the polyclonals are way below the threshold of about 30%. The observed mean read length is about 188 base pair, which is more than the minimum 150 base pair for a good, accurate downstream analysis. The expected number of reads per sample is about 4 to 5 million, and this amount is important to call the copy number variants accurately. And the other QC metrics are mean depth, which should be more than 200 times, but if you look at here, it's about more than 300 times overall. And the uniformity expected is more than 93%, but in this run, it is more than 94%. So overall, this is a very healthy run for downstream data analysis for copy number variations and mutation analysis. Expanded cardiac workflow also comes with a pre-configured pipeline in the iron reporter software for automatic calling of single nucleotide variants, indels, and copy number changes. So we don't have to heavily depend on the in-house bioinformaticians to make sense of all these variants coming from over 400 genes. So it's a very easy workflow in the wet lab and also in the dry lab. So expanded carrier screening also comes with a very user-friendly carrier reporter software. It gives the flexibility to add your own header and footer. Analysis could be done on cloud version or on a local server, but at our lab, we used the cloud version and the experience was as good as a local server. And software also handles digenic variant analysis, for example, Southeast Asian deletion, which removes both HPA1 and HPA2, other deletions like Mediterranean or Thai deletions on both HPA1 and HPA2. So it really is a wonderful software that is associated with the expanded carrier screening workflow, and we find it extremely user-friendly and easy to report and easy to analyze the data. And this is a typical report generator from the carrier-seq reporter software. You can add your own header and footer of your institution, as I have done here, and you can add your client information and etc. The software uses bright color boxes to indicate different types of variants. Pink color is used for X-linked disorders as shown on the left bottom of the screen. Orange color for compound heterozygous changes as shown on the top right of the screen. And yellow color represents the autosomal carrier status as shown on the right bottom of your screen. So I have two cases to present because of the time constraint. I only will limit only two cases. So this is case number one. It's a Chinese couple, non-consanguineous marriage, no family history of genetic disorder up to 2 generations. So the only thing they have found noticeable is that when they did the complete blood count, the MCV was a bit marginally low in both husband and wife. So they were offered expanded carrier screening, not because of the low MCV count, but then for the general screening, expanded carrier was offered for this couple. For the husband, husband is a carrier for single gene deletion on alpha globin gene. So with a 4.2 deletion, so he is a carrier for alpha thalassemia. And wife is also a carrier for alpha thalassemia, but the wife has got a double gene deletion called Southeast Asian deletion, which removes both alpha HPA1 and HPA2 gene complex. And wife is also having another mutation on that results in hemochromatosis type 1. But the important finding for this couple is that both are carriers for alpha thalassemia. Husband is a single gene deletion, wife has got a double gene deletion. So therefore, there's an increased risk of about 25% chance of this couple having an HPH disease, which will cause moderate degree of anemia, microcytosis, and sometimes occasionally you may require blood transfusion for this couple. So after genetic counseling, the couple opted to do IVF and PGT-A and PGT-M. And you can see the results at the bottom of your screen. They had 5 embryos from the IVF cycle. The first embryo is a euploid embryo with 4.2 deletion. So this embryo will be a carrier for alpha thalassemia with a single gene deletion. Embryo number 2 is euploid, and the alpha thalassemia alpha globin gene complex is completely normal. Embryo number 4 is again euploid with hemoglobin H disease. So this is the embryo. This is the type of embryo or the pregnancy that we are trying to avoid by giving the opportunity to do PGT-M carrier screening followed by PGT-M. So this couple was implanted with embryo number 2 and have a healthy pregnancy ongoing now. This is case number 2, where it's a consanguineous marriage from an Indian Malaysian ethnic group, and they report family history. They have an immediate history of a child. They have lost a child at the age of 1 with liver disorders, and presumptive diagnosis was Wallman disease. So the couple was offered a carrier screening, and then we noticed that there's a point mutation in the LIPA gene. Both husband and wife carry the same mutation, and probably this is because of the consanguineous marriage between them. So again, this couple was offered PGT-A and PGT-M, and this couple had got 3 embryos. Embryo number 1 is euploid, homozygous normal. Embryo number 2 and 3 are aneuploid, so they cannot use this embryo. And luckily, this couple has got 1 embryo that is completely euploid and mutation-free on the LIPA gene. So this shows that rare genetic variants, especially these private mutations, can be found in any ethnic groups and any population, and expanded carrier screening would help such couples and give hope for a healthy family. So immediate use of carrier-seq at GenomixLAB is we will be using this as a laboratory-developed test, mainly to screen egg and sperm donors. And also this panel will be used for carrier screening for couples to assess their risk of developing an abnormal genetic disorder baby. So some of the benefits of using expanded carrier screening is that it is an excellent tool that focuses on the risk assessment of individual conditions. And this panel is a pan-ethnic panel which is suitable for multi-ethnic subpopulations like Malaysia and India. And it's an easy to integrate workflow into our routine wet lab and the dry lab. And one of the limitations that is shared amongst most of the expanded carrier screening, that it is not able to analyze the repeat expansion diseases like Fragile X syndrome and other myotonic dystrophies or spinal cerebral ataxia kind of repeat expansions. So these are common limitations for all expanded carrier screenings. So with that, I will conclude my presentation, and thank you very much for the opportunity given by Thermo Fisher to share our experience on expanded carrier screening. Thank you very much.
Thank you, Dr. Saleem, for that very engaging presentation and sharing your experience with us. Excuse me. I will now open the session for questions. And as a reminder, please submit your questions via the Q&A box. Okay, let me just go to the questions. Okay, we've got a few questions coming through. And the first question we have, Dr. Saleem, is that towards the end of your presentation, you mentioned about the panel that you use is a pan-ethnic panel. How important is it to use a pan-ethnic panel for carrier screening in today's society? and particularly in a population such as the Malaysian?
Yeah, thank you very much for that question. Yeah, so Malaysian population, like many, is a mixed population. Here we have about Indians, Malays, Chinese, and other small minorities from Punjab. So it's a very complex population here in Malaysia. I think it's very, very important that we don't use smaller panels, target panels for populations like ours. And it gives us a lot of opportunity to use a single panel that is suitable for the entire population. And especially if we were to use this kind of panels in IVF centers. As you know, in IVF centers, you have a lot of patients coming from different societies, different populations, especially from overseas. If you're promoting medical tourism, so you will have patients coming from China, India, so many countries will be coming to IVF clinic. So if you were to have a smaller panel, target panels, you will not be addressing to these diverse populations. So I think it's really, really important to have a broad, expanded carrier screening panel that can be used for any given ethnicity. Yeah, so we find these kind of panels very useful when compared to the previous panels that we were using, more focused to local population. And it addresses to private mutations that are in small minority populations, especially in consanguineous marriages. Yeah, I hope that answers the question.
Great. Thank you, Dr. Saleem. So another question that we've got come through is that they're screening for common single gene disorders, or just a few common single gene disorders. Would you recommend that they switch to expanded carrier screening, and why?
Yeah, definitely I would recommend to use an expanded rather than a small single targeted panel, because for the reasons that I just mentioned earlier, our populations are getting very diverse. So if you use small gene panel, you will be only addressing very few mutations, and you will be not addressing the complete risk assessment for that couple. Because when we do an expanded carrier screening and you're looking at about 400 over genes, so the risk assessment that we give for the couple is a very comprehensive one. But if you use a smaller focus panel for that ethnic group, you are not addressing the entire risk for the couple, and so that the risk assessment that we give will be very limited. So therefore, the chances of missing an important mutation is much higher when you use a smaller panel when compared with a larger panel.
Great. And another question that we have relates to variants of unknown significance. And when you're doing the sequencing, do you get any variants of unknown significance, and what is your reporting mechanism?
So, of course, when you do an expanded carrier screening, you will get uncertain significant changes that are not reported in the literature. So, at GenomixLAB, we do not report the variant of uncertain significance, because I believe that it has no role in reproductive genetics, unless, of course, the couple has got a family history to show that this mutation is associated with the phenotype that they are describing. Unless otherwise they present with this kind of information, we do not report variants of unknown significance. But we keep all these records so that they can visit the data in a subsequent pregnancy. And what we do is we will be looking at the data every month to see whether there is any change in this interpretation. And if there is any change in the interpretation, we will immediately inform the couple that there is a change in the interpretation, so that they can plan the pregnancy for the subsequent pregnancy. So once you offer an expanded carrier screening, you only offer one time in a lifetime. You don't have to repeat it for the subsequent pregnancy. You just have to revisit the data to see if there is any interpretation changes in those, especially those variants of unknown significance. So in a single line, I think what the answer is, we don't report variants of unknown significance unless there is reason to believe that it is may show some phenotypic changes in that family based on the clinical history they are presenting with. Michael?
Yeah, and I think we have time for one last question. And so, at the start of the presentation, you talked about combining multiple tests into a single assay. So how much of a difference does that make to your lab?
It really makes a big difference because if you were to do multiple panels like MLPA, we have to have about 10 kits doing 10 MLPA reactions for 10 different copy number changes. And it occupies a lot of time, staff time, and then analysis time. And also you'll be doing other targeted PCR tests. So it consumes a lot of time to analyze and run these tests. So with the shift into to this expanded carrier screening, the workflow is really easy. Only one person is handling these samples, and in the lab, I think it's very convenient to have this expanded carrier screening, which really addresses to the copy number changes plus mutation screening and basic variant calling. So it gives a lot of comfort and for both the lab, wet lab, and also the dry lab, and also we are more comfortable in reporting this data to our clients in order to give a risk assessment to these prospective couples. Michael?
Great. Thank you very much, Dr. Saleem.
You're welcome, Michael.
And thank you to the audience for the questions that came through. I'm sorry we don't have time to address all of those questions, but those that we didn't answer, we will try and address by email at a later date. Our next speaker in this session is Dr. Yong Ju Jiong, the Chief Strategy Officer of the Division of Product Development at Theragen Genome Care in South Korea. Genome Care conducts genomic research as well as offering genome-based testing services. Dr. Jeon will be sharing his experience at Genome Care and how they have been using the ion torrent next-generation sequencing and pre-implantation genetic testing for reciprocal translocation carriers in the Korean population. I invite Dr. Jeon to give us his presentation. Over to you, Dr. Jeon.
Let me just say thank you for taking your time to be here today. As previously noticed, the subject of this presentation is current status of pre-implantation genetic testing for reciprocal translocation carriers in Koreans. The majority of clinical indication on pre-implantation genetic testing is benign carrier with genetic problems in Korea, and the number is being steadily increased. In this time, I'm here to describe our statistical data from the population of benign translocation carriers between September 2019 and May 2020. I'm going to give an overview of geographic characteristics and major indications of pre-implantation genetic testing, PGT. According to the report from Reproductive Biomedicine Online in 2017, about 3,300 of IVF cycles was performed globally, and 263,000 of IVF had a history of PGT. However, a considerable number of clinics in Asia, Europe, and Africa performing PGT during IVF cycle, in contrast to the others, America, Australia, and New Zealand. The major three indications of PGT are advanced maternal age, repeated implantation failure, and recurrent pregnancy loss to be about 90% of distribution. The next is statistical data of preferred biopsy method to be used for PGT. The frequencies of breastomere biopsy and trophectoderm biopsy to be executed for PGT were 25% and 72% respectively. Polar body biopsy may be carried out due to PGT, but it was only 3%. This slide is for statistical data of preferred test method to be used for PGT. The frequencies of array-CGH and next generation sequencing to be executed for PGT were 59% and 16% respectively. Currently, the next generation sequencing method ranks second in overall market share, but it is expected to be more widespread and present the gradually increased rate. To evaluate the PGT statistical data from benign carriers with genetic problems, it is necessary to review previous historical data of PGT for hereditary disorders. In January 2020, systematic review for unemployed prevalence of PGT cases with inherited disorders was published in Acta of Obstetricia et Gynecologica Scandinavica. All included study data were from PGT-SR or PGT-M cases. The distribution of unemployed prevalence ranged between 20% and 80%. Above half of the studies, the detected unemployed rate was more than 30%. This slide presents measures for clinical outcomes after receiving PGT in contrast to the other conditions. The PGT was shown in blue and the others in green. Overall, the historical data have shown a beneficial effect of PGT in maintaining pregnancy. Reciprocal balanced translocation does not produce any chromosomal copy number changes and usually presents a benign phenotype. However, the genetic problems may occur in the next generation. Half of offspring from normal and balanced translocation carrier parents may have abnormal chromosomal copy number. Therefore, the PGT objective of balanced translocation carrier is generally to rule out risk of chromosomal microdeletion or microduplication. The previous literature identified beneficial effects on the balanced translocation receiving PGT in 2019. PGT contributed to reduce the risk of birth defect and adverse pregnancy outcome, but increased the rate of normal live birth. Moreover, the numbers of severe congenital anomalies were significantly lowered after receiving PGT. There are three main objectives of this survey as follows. First, it is to examine transferable embryo prevalence in Korean balanced translocation carriers. Second, it is to consider how many number of embryos may be required for at least one normal copy number embryo. Third, it is to find out critical factors including maternal age, gender-specific causes, and biopsy method associated with is of normal copy number embryos. We use the sequencing libraries with ion leprosy kit. The pre-amplification PCR cycles was of the terophthalmia and blastomia were 12 cycles and 15 cycles respectively. The QC cutoff of library concentration was 10 nanogram per microliter, and final concentration of library pooling is 80 picomole for ion S5 sequencing. The data analysis was performed with ion repeater version 5.10 software, and undeployed mosaicism filter was applied to detect partial chromosomal deletion duplication. The QC cutoff of uniquely mapped sequencing leads was 100,000. From September 2019 to May 2020, the test records of 124 couples with male or female benign translocation carrier were collected for this survey. Table 1 represents demographic characteristics of enrolled 124 couples data. The mean female age was 36 with standard deviation as 3.9. The couples with balanced translocation requested about 6 embryos on average. Approximately 40% cases were male translocation carrier, while 60% cases were female translocation carrier. Only one couple had both male and female translocation carriers. Above 80% of couples were examined using terophthalmia biopsy to exclude chromosomal deletion duplication risk. Table 2 demonstrates the prevalence of normal copy number embryos according to age, test number, gender-specific factors, and biopsy method. Of the 728 embryos, about 20% of embryos have normal copy number chromosomes. Earlier female age and terophthalmia biopsy presented beneficial effects on increased yields of transferable embryos. There were not significant differences in test number and gender-specific factors. Table 3 describes the rate of couples with at least one transferable embryo regarding age, test number, gender-specific factors, and biopsy method. Of the 124 couples, 80 couples obtained at least one embryo of normal chromosome number without partial deletion or duplication. There were significant favorable effects in the condition of below 40 years of female age, over 6 tested embryos, biopsy. Table 4 shows the proportion of couples with at least one embryo with above 3 multiple aneuploidies. Of the 124 couples, 95 couples had at least one embryo with over 3 multiple copy number ablations. The frequencies of the embryo with multiple aneuploidies were higher in advanced female age and blastomia biopsy. Table 5 presents the attendance rate of couples with at least one embryos of normal copy number in previous PGT tests. Of 80 couples, Only 9 couples had experiences of reattendance despite the presence of normal copy number embryo in the PGT test. Advanced female age was associated with an increased reattendance rate, implying adverse pregnancy outcomes. In conclusion, we could find the significant factors affecting yields of transferable embryos from the statistical data of translocation carriers receiving PGT. First, the conditions with below 40 years of female age and 12 ectoderm biopsy were recommended to increase yields of embryos with normal copy number. Second, the of tested embryo were approximately 6 to achieve about 80% yields of transferable embryo with a normal copy number. Third, male balance translocation factor presented negative effects on yields of normal copy number embryos. It is the end of this presentation. Thank you for listening.
Okay.
Thank you so much for the.
Okay, sorry, I think there's been some technical issue with my audio. Sorry, Michelle, back. Yeah, so thank you, Dr. Jeong, for the wonderful insight into your pre-implantation genetic testing for reciprocal translocations in South Korea and sharing your experience with us. I will now open this session for questions. And a reminder, if you do have any questions, please submit them via the Q&A box. So we have a few questions that are coming in. And the first question we have, Dr. Jeon, is what was the distribution of the translocation size in the enrolled couples of this study?
The distribution of the translocation size was from 4 megabase to 30 megabase in our data set.
Okay. Second question that we have is what is the definition of reattendance? Can you expand what does that mean?
The definition is PGT test cases were done after at least 4 weeks despite of transferable embryo in the previous test.
Okay. Okay. Another question that we have, and I'm going to ask you to speak up a little, Dr. Jeon. It's a little soft. Was the case of both male and female translocation carriers able to find a normal embryo?
Unfortunately, they could not find any copy number normal embryos.
So what was the follow-up for that couple? Did they do another cycle?
Yes, they have 2 additional cycles.
Okay. And you mentioned, you showed data at the beginning of the presentation around array CGH and next generation sequencing. So
yes.
What advantage does next generation sequencing have over array CGH for pre-implantation genetic testing for reciprocal translocations?
Cycle. Can you speak question again, please? Sorry.
Yeah. I'll rephrase it. What benefit does next generation sequencing give for detecting reciprocal translocation for PGT?
The next generation sequencing have more higher analytical sensitivity than RACGH because RACGH only have around 3,000 probes, but next generation sequencing have around 300,000.
Okay, so I think for those more technical questions, we can address them later via email. Okay. So still waiting for a couple more questions to come in via chat. And we've not got any more questions coming in. So thank you again, Dr. Jeon. And I would like to thank the audience for their participation. And we will try and answer any questions that you do submit after. We'll try and answer those via email at a later date. So once again, thank you very much, Dr. Jeon, for that great presentation. Our last speaker for this session is Dr. Ritu Hari from Kraft Hospital, India. Dr. Ritu is a certified genetic counselor, and she holds a PhD in reproductive genetics from the United Kingdom. Dr. Ritu heads the PGD laboratory at Kraft Hospital and is credited with performing India's first PGT for monogenic disorders for a Tay-Sachs mutation carrier couple leading to a live birth, as well as a successful live birth from an SMN1 mutation carrier couple, and has been involved in many other PGTM cases. Dr. Ritu has published many chapters and articles in reputed journals and books, and was part of the PGD consensus to frame the guidelines for India as an initiative from the Indian Society for Assisted Reproduction. Welcome, Dr. Ritu.
Good morning, everybody. First of all, I would like to thank Thermo Fisher team for giving me this opportunity to present the reproductive genetic-based services on NGS. I have been a customer and have been using Thermo Fisher's NGS platform INS5 Excel from past 5 years now. And I'm into mostly reproductive genetics-based tests like PGS, PGD, NIPT, and even clinical exome. And we have recently introduced PGT-M also on NGS. So in my today's presentation, I'm going to be talking about what different levels of genetic investigations, in what different levels of pregnancies can these genetic investigations be done, and what are the number of advantages a single platform like NGS can provide us. So basically, the genetic culprits in any kind of pregnancy, be it a natural pregnancy or an IVF-related pregnancy, miscarriages due to chromosomal abnormalities are seen in a higher rate. Whichever pregnancy is getting spontaneously aborted before 3 months of pregnancy are said to be caused due to 80% of the times due to chromosomal problems. So these chromosomal problems, they form the hallmark, which are very important, and what we refer to as aneuploidy. Now, euploidy is something individual having normal set of chromosomes, that is 23 pairs, and aneuploidy is something which is plus one chromosome or minus one chromosome, or plus or minus multiple chromosomes which are not compatible with human life. Now, conception is definitely God's gifted thing, but then when some conceptions carry on to normal delivery, to normal pregnancy and delivery at term, but some conceptions can miscarry before 3 months, mainly due to chromosomal problems. So those are referred to as aneuploidy pregnancies. And then there are some DNA-related problems. Basically, genetic problems are classified into chromosomal and DNA-related problems. In DNA-related problems like conditions like spinal muscular atrophy, thalassemia, Tay-Sachs, etc., parents are carriers of any known genetic condition. So these DNA-related problems will not cause miscarriage in the couple, but can go on to produce children who can be genetically abnormal if they are carriers of any known mutation. So now on NGS, we can tackle both chromosomal-related problems, DNA-related problems, and also genome-wide problems. So now what are the levels of genetic investigations? Traditionally, in earlier days, we had only prenatal diagnosis. That is, when a fetus is formed in the mother's womb, at around 12 weeks of pregnancy, we do a chorionic villus sampling to diagnose whether a fetus is affected with a genetic problem or a chromosomal problem, depending on the indication. Now we are in the era of pre-implantation genetic diagnosis or testing, where we can diagnose these abnormalities in the embryo level. And that has happened because of the greater technologies like NGS. And then we also have something called postnatal genetic diagnosis. Now, when I say postnatal, that is after the birth of a child. If there is any abnormality, we can do a clinical exome sequencing. That is, we can cover all the coding regions of the genome or the DNA, and we can come to know as to what genetic problem exists in the indexed child. We can offer them a targeted screening. Now, in my subsequent slides, I have put an example of all this and shown how these different screening methodologies can be applied. And then we have something called expanded carrier screening as well. Now, exome, let's have a scenario. Exome can be done on a couple who have had a child with abnormality and they are suspecting to be genetic in nature, and so that we can take care in the next pregnancy, we can offer them an exome sequencing. Many of the times the couple can lose the child, that is the index child may be no longer surviving. So in those cases, we can offer them an expanded carrier screening on the couple where we can come to know what actually the genetic basis of the disease was. And targeted screening is something where you know which gene can be affected depending on the clinical features or clinical manifestation, and the geneticist can advise a targeted screening. So all these kind of genetic investigations are possible on NGS in a single platform. So now coming to the technologies, in the embryo level, the first generation of PGS or PGD or PGTA, what we call now, we had the FISH technology where limited number of chromosomes were checked. From then started the science of pre-implantation genetic testing on embryos. Though FISH did not prove to be very effective in determining the clinical pregnancy rate, still the research went on, and then array CGH was developed. Array CGH is a technique where known samples can be used as controls, and then you can have unknown samples tested against them. But the only problem with array CGH was only limited number of samples can be run together. And then after array CGH, even the NGS platform was developed, and we had the first baby born in 2013 after performing PGS on NGS. We have INS5 XL in our laboratory where we offer PGTA, M and SR for our couples. So in NGS, the basic advantage of performing multiplexing, that is you can run up to from 24 to 396 embryos, and then you can multiplex them together, providing lot of clinical information. So that is the advantage of NGS over FISH or array CGS. The accuracy increases. There is a high increase of likelihood of accuracy. Now, there is something called time-lapse where debate is still going on. Time-lapse is a technology where people are using it to determine the morphokinetics of the embryo. Determining the morphokinetics itself might not be very helpful because we need to know the genotype as well. So both genotyping using NGS technology and also the time-lapse morphokinetic can actually increase the pregnancy rate in an infertile couple. So these are the technologies. Now, any challenges before pregnancy, a couple trying to conceive for years can be either recurrent pregnancy loss, as I have mentioned, or can be recurrent IVF failures after putting top quality blastocyst if the pregnancy gets failed to achieve. We have come across many scenarios like that. So what next can be investigated? And on these couples, already the factors like endocrine, biochemical, and immunological factors have been ruled out. So in our country, like India, still there are some debates and controversies where clinicians do not accept genetics or genetic investigation as part of infertility treatment. They are least ignored. They are ignored. But then we cannot ignore that is not the answer. We need to have a basic investigation of karyotyping done on couples, and then only we will be able to further tell what could be the next role of treatment. So how we can evaluate the success with PGTA? PGTA is for checking chromosomal aneuploidy. So we know that 2/3 of clinical miscarriages are always caused because of chromosomal aneuploidies. And some aneuploidies may be observed in miscarriages and some may not be observed because some pregnancies can get aborted even before it has got clinically confirmed. So that can be under the category of implantation or developmental lethal. The embryos may get arrested and may not give rise to pregnancy. So IVF implantation also decreases with increasing age, and we know that with the increase in age, the aneuploidy rates among elder women also increases. So So natural pregnancies also have an age-related risk where you can have higher incidence of trisomy 21. So these are some of the causes why NGS-based PGTA should be offered to couples. Now, how do I convince my patients for PGT in my lab? Even though the normal karyotype of couples are usually seen, there might be aneuploidies in embryos because pre-implantation stage embryos can have aneuploidies. Even the mitotic errors should not be ignored. Anything which is growing in vitro, that is outside the human body, can give rise to aneuploidies. So even mitotic errors, mitotic errors should also not be ignored. So you should advise the couple. Meiotic errors are something we know that it is present. So that is gamete related or couple related. Both meiotic and mitotic errors can be well taken care. So maternal meiotic errors are more high in advanced age, and even paternal meiotic errors can be high, especially when you are running a male infertility clinic, plus when you see a lot of males with azoospermia, that is zero sperm count, you can have a lot of meiotic errors in their DNA. So that can also give rise to aneuploidy in their embryos. And post-meiotic abnormalities are also common in younger women. There are many recent articles which throws light on that. And aneuploidies, as I said, in advanced maternal age movement is also present. So these are some of the convincing facts which can be talked to the patient. Now, this is one of the report of our laboratory where I wanted to highlight. You can select the most viable blastocyst, euploid blastocyst. Even the mitochondrial DNA ratio can be predicted in a single run. In the same biopsy, you can get a lot of clinical information. Apart from knowing the aneuploidy status, you can get to know the mitochondrial DNA ratio also. So in this case, there are 4 embryos which are found to be euploid or normal, and they are recommended for transfer. The other one you can see here, it is an undiagnosed where the DNA of the embryo, DNA from the embryo was not sufficient enough for us to define whether it is normal or abnormal. So in such scenarios, you can leave the decision between patient and the clinician. So coming to an NGS karyomap, this is one of the karyomap which shows all the comprehensive pair of chromosomes being screened here. And obviously this is abnormal to transfer. It has a monosomy of chromosome number 9, which is red color here, and a monosomy of chromosome 14. So you can see even though the karyotype of was normal, the pre-implantation genetic testing of one of the embryo revealed abnormality in chromosome 9 and 14. So it can be due to either meiotic reason or mitotic reason. This is of course not fit for transfer. Now, another important point I wanted to focus here, NGS calls the mosaic status of the embryos much better than array CGH. A mosaic is something you have different cell lines, that is one cell line having normal chromosomal complement and other cell line can have different chromosomal complement. So in comparison to array CGH, this was a case where it was misdiagnosed by array CGH but then correctly picked up by NGS. Now, genetic evaluation of recurrent spontaneous abortus samples is also one of the area which is now very much picking up in the regular obstetric gynec practice. The traditional method of fetal karyotyping was cell culture methods where geneticist 99% of the time fails to give the result because of the cell culture failure of the abortus. Now, thanks to the technologies like NGS, where we can actually, there is no need to go ahead with the regular culture method. You can extract the DNA from the abortus, do a maternal cell contamination check, and then go ahead with the NGS testing, and then you can give the ploidy result. So this is one of the results from my lab where trisomy 16 fetus was detected in one of the abortus, the first figure here. Then monosomy X was detected in the next fetus. And then we have a trisomy 22 fetus showing up the abnormality. So such kind of abnormalities can be picked up in if you do a karyotype for the product of conceptus. Now, why it is important to do a karyotype? Because even though some patients might not do a regular karyotyping or a basic karyotyping, they will not know the reason of their recurrent spontaneous abortion. So doing at least one abortus karyotyping will reveal if that particular aneuploidy is getting recurrent in the pregnancies or it's not getting recurrent. Monosomy X can be due to sometimes X chromosomal abnormalities in the mother or can be due to in the father as well. So it's always better to offer a karyotyping of the parents before you have them in your IVF clinic. So parental karyotyping is very, very important. There are no specific guidelines in India, but as a personal experience, even as you can see in this case, even this particular female was less in age, though her maternal age was less, and she had a second miscarriage. When we had some suspicion, we did a karyotyping, and it was revealed that she is a balanced Robertsonian translocation between chromosome 13 and 14. So this female could have suffered more miscarriages, and we would not have known the genetic reasons. We would have investigated the other investigations but could have missed. So she is a candidate of PGT-SR. Now I'll be speaking about PGT-SR in my next slide. So in such scenarios, it is must to have a karyotype done so that we can advise them for further treatment. So PGT-SR is something, as I have shown you in the karyotype, there is a breakage of one particular segment of chromosome, and the other segment of the particular segment get attaches to the other segment of any part of chromosome. So such scenarios are referred to as balanced translocation, where the female or male can be carriers of the balanced translocation and they can be normal. But when they reproduce, problems pop up in their gametes, and the gametes or the embryos which turns after the fertilization, where we can see a lot of abnormalities due to those translocations. Now those translocation abnormalities can actually be picked up in NGS, and we refer to as PGT-SR. The dilemma or the irony of Indian scenario of not offering PGT-SR in those couples, we wait for 3 abortions. But then if patients are willing, if you have a karyotype, then if you have an answer, you can even offer them with one or 2 abortions, because you don't want the patient to miscarry. It creates a lot of psychological issues among the patients. So this is one of the cases where a female aged 34 years, she was presented to us with primary infertility. Her karyotype revealed translocation between chromosome 2 and 13. Now, interestingly, this couple did not have any abortions, but their reason was primary infertility. She never conceived. Now, some translocations, unlike the Robertsonian translocation, can give rise to implantation failures. The couple may not even recognize whether they got pregnant anytime. So such cases, actually, it is easily being dealt by PGT-SR. Only thing is you need to counsel the embryo. You need to counsel the patients to have more number of embryos, so that you can send them home with a baby, with a good take-home baby rate. So we counseled them. We biopsied around 10 embryos, and we transferred 1 normal embryo, and now we have an ongoing pregnancy. So this is her report. We could do a biopsy on day 3, and then we could get the DNA in all these. You can see quality control had been passed in all the embryos, all the 10 embryos, and out of that only 1 was normal. So we now have a ongoing clinical pregnancy. So this is the data from one of our embryos, where correctly the NGS has picked up the whole chromosome unbalanced translocation. She had a translocation between 2 and 13, so it has been picked very nicely. Chromosome 2, there is a blue line suggesting trisomy 3 copies, and chromosome 13, a red line suggesting a monosomy, that is 1 copy of chromosome 13. This was one of the examples. Now we do something called targeted mutation testing, which is also possible in NGS. We can sequence the suspected gene, like the fibroblast growth factor gene in one of my cases. Also beta-hexosaminidase gene, which causes Tay-Sachs disease. Now, a couple came to me almost 3 years back for genetic counseling. In the couple, male side had no family history, but male had skeletal dysplasia. He underwent skeletal extension, but no genetic investigation was done. The suspected gene was, of course, FGFR3, where I ordered for targeted mutation screening on NGS, and interestingly, we found a mutation in one of the exons here. So he was a candidate for PGT-M, that is monogenic defect, because they had a history of primary infertility and they never conceived. Husband has some semen abnormalities and sperm abnormalities. So they were candidates for IVF, and then PGT-M, they wanted it because there is a 50% chance for them to have an affected child. So we already have twins born out of this particular parent. we could do a PGT-M on them, and then we have now twins who are 1 year old. This is one of the successful cases. Now coming to monogenic diseases, you have autosomal recessive conditions where both parents can be carriers and there is a 25% risk of transmitting. You have autosomal dominant condition, as I have shown in my example. You have 50% of it to get transmitted, and then you have X-linked recessive, example hemophilia, Duchenne's muscular dystrophy, etc., where mother can be carrier and she can pass on the defective gene to her son. So NGS has made it very much possible through a very robust indirect approach where you can offer PGT-M for any type of genetic condition, provided you have a family history. The mutation should not be de novo. That is, in family, the father or the mother or the grandparent should have that mutation. So that is referred to as linkage-based analysis. Now, linkage-based analysis has been traditionally used in all the PGT-M cases earlier, where few linkage markers around that particular gene was developed for any disease. Namely, 2 or 3 linkage markers were used, and which are informative, where, are diagnosed accordingly. So in NGS, it is basically pan-ethnic population where we can use up to 200 to 300 SNPs for linkage-based analysis, and we can generate a haplotype of the embryo. Here you can use grandmother, that is the parent's sample if you suspect a family history, and then the parent sample, and then the embryo sample. And if you have an affected child already, even the affected child sample can be used. And imagine the accuracy of NGS-based technique that you can generate million number of reads across any embryo, across any parent sample, and then compare them. So linkage-based analysis is generally comparison between these controls and the embryos we generate and gives us an accurate report. The advantage of doing a linkage-based analysis is you can reduce the allele dropout to even nil, even 0. I have done 3-4 cases by using the NGS-based panels in my laboratory, and I have seen good results. So coming to the data analysis part of the linkage-based analysis, the orange one is actually affected here. The green one is normal, that is the wild type. You have male and female who are carriers of a recessive condition and child who is affected. These are the embryos. The embryo 1 here is basically affected, that is 2 red. The second embryo is a carrier. The third embryo is also a carrier, and the fourth embryo is normal, which has the wild type allele. Now, this kind of phasing is usually done by a special software which comes along with the panel. And after the phasing, you can generate alleles accordingly. You can compare them using a linkage-based study and then give embryos a genotype. Now, a case study where we did recently, and here clinical pregnancy is just ongoing. A female aged 29 years was found to be affected with Huntington's, and here is her report, where 73 base pair allele was repeated, and this is a repeat expansion disorder. We did indirect approach-based PGT-M here. We took the sample from father. Her father is basically affected with the Huntington condition, and her mother was normal. So we used mother sample, father sample, and the daughter sample, against which we compared with embryos. So we had actually biopsied around 10 embryos, and out of 10 embryos, we had 1, 2, and 3 being normal. So we have transferred one of the embryos, only one embryo clicked, and that resulted in the clinical pregnancy. So one embryo, we could not give any conclusive results based on the data generated. So here we can say it's an indirect approach because we do not know we just know the diseased part of the gene, that is in such repeated expansion disorder like Fragile X or Huntington's, linkage analysis is the best and it serves the purpose because you can know the location of the gene as well. Our second case dealt here was for SMN, spinal muscular atrophy, where couples were carriers of exon 7 deletion. They had lost 2 children before. We explained them the risks and they wanted to go ahead with the indirect method, that is haplotyping. While indirect here, exon 7 is a bigger deletion, so we need to define the linkage or SNPs based on that particular gene. So we collected grandparent sample. 12 embryos were tested again and 4 normal was there. and patient had transfer of one normal embryo and she delivered a healthy baby. Baby is now 8 months old. So these are some of the success stories of our PGT-M based NGS platform. This is the result where we could biopsy around 12 embryos, and we have also done a PGT-A. I wanted to highlight, though this is a normal embryo for SMN exon 7, there is no deletion, but it is a trisomy 13 embryo. So had it been we did not do a PGT-A, we could have wrongly transferred this embryo, which would have led to pregnancy loss, either pregnancy loss or this particular chromosome is compatible with live birth. Of course, we would have advised NIPT, things like that, but then in the embryo level itself, if you can biopsy, in the same stage of biopsy, if you can come to know both PGT-M and PGT-A results, then there is no harm in telling the patient. But my only advice is, after offering PGT-M, after getting the PGT-M results only, you should be offering PGT-A. So the clinical advantages of NGS is it improves implantation rates for some patients, for patients with PGT-A, PGT-SR. It decreases the unnecessary transfer for most patient types, that is young. Imagine a cohort of young patient who has more embryos on day 5. We do not know which one to transfer. So in such cases, you can actually, after offering them a PGT-A, you can know which is euploid and which is aneuploid so that you don't transfer aneuploid embryos. It, of course, decreases miscarriage rates and minimizes miscarriage rate, especially for advanced maternal age women and translocation carriers, as I have shown before. You can also offer a single embryo transfer cycle as a real option without losing pregnancy rates. And also you can avoid multiple gestations. These are some of the clinical advantages of offering NGS. NGS, technically, it has high throughput. The cost has been drastically come down by multiplexing technology and using barcodes. You can offer both PGT-A, SR, or M in the same experiment. You get additional genetic information which is clinically relevant, and of course, it reduces time to pregnancy. So now one of the important science now we are coming to is NIPT. NIPT is being done from quite long now, and nowadays many Indian laboratories are actually replacing triple test or quadruple test, the regular biochemical screening with NIPT. So this is I don't have much time to cover NIPT. In a just nutshell, NIPT is non-invasive prenatal testing which is offered to pregnant women at 11 weeks. Or 10 weeks, 10 to 11 weeks. It can be offered after 11 weeks also, but in our clinical setup, we advise them at 10 to 11 weeks. The cell-free DNA, which is present in a very smaller amount, passes through the placenta and then flows into the mother's bloodstream. In NIPT, we do not sequence only the fragments of fetal DNA. We sequence both maternal and fetal DNA both. And of course, we do a counting method using MPS-based technology, which is massive parallel sequencing. And counting method tells us whether the fetus is at risk of having a trisomy or not, or a monosomy. This is a full comprehensive chromosome result from our laboratory where we screen up to 23 pairs of chromosomes. Sex chromosomes are not revealed unless we see any abnormalities in the sex chromosome. Another advantage, personal advantage I have seen of offering NIPT is sex chromosomal abnormalities like monosomy X, triploidy, triple X cannot be picked up by regular biochemical methods, or even ultrasound scan cannot pick up these abnormalities because only once the baby is born with such problems we will come to know. So the advantage of having an NIPT done for all IVF pregnancies, I would say, is you can get to know the sex chromosomal abnormalities well in advance for us to take a clinical decision. With this, I would like to conclude. Thank you very much. I hope I have covered all the reproductive genetic services and techniques which can be performed on NGS. Thank you very much for your kind attention.
Thank you, Dr. Ritu, for sharing those inspiring stories and detailing how you combining both pre-implantation genetic testing for aneuploidy as well as for pre-implantation genetic testing for those monogenic disorders using a single next-generation sequencing platform, saving both time and costs, while helping those couples have healthy babies. I am now going to open the session for questions. And again, I encourage you all to put your questions into the chat box, and we'll relay those to Dr. Ritu. And I see a few questions that are coming through, and I'm not sure exactly what this one relates to, but the question here, Dr. Ritu, is although NGS is advantageous over fish, in several experiments, fish is still used. Apart from the reason that NGS is not available for that lab, are there any other reasons why fish is being used?
All right. I think this question is being put by R3 Joy Das. So I would like to first know, depending on what test she wants to do fish. If it's for prenatal sample, yeah, I would say fish is gold standard because the turnaround time of results is quite fast. But when it comes to PGSR for constipation couples or for target chromosomal 3D, these days every other implantation genetic testing is all based on comprehensive chromosome 3D. So clinicians need full reports, that is the 20 pairs chromosome report for on so it depends on what type of test is used for. If it's for prenatal, I would say fish, but when it comes to implantation, NGS is the best.
Okay. Dr. Ritu, there's a bit of echo and a bit of breaking up in your voice, so if you can speak a little louder, that's okay. No problem. Anyway, next question. Next question. What kind of test would you suggest the patient to start with if there is no family history, then PGTA plus karyotyping first? What would be your recommendation?
What kind of test would you suggest? Now, depends whether it is for a gene defect or
I'm sorry, Dr. Ritu. Sorry to interrupt, Dr. Ritu. The voice is very breaking up, and we can't really understand.
Michael, I'm trying my best. The sound is echoing.
That's much clearer. That's much clearer.
All right. So it depends on what kind of genetic test. Depends on the indication. If couple have had previous pregnancies also, karyotyping is the gold standard for both couples. And if it is a recurrent implantation or IVF, karyotyping without explantation. If for a family history or a single gene child born with a abnormality, then they would say a carrier screening will be done first to identify. It all depends on what kind of to be tested. Michael?
Yeah, okay. So next question that we have here is, can genetic testing be done on Myometrium if there is frequent miscarriage?
Genetic testing on Myometrium. I have never tried. Myometrium, can I have a clear idea as to what kind of tissue and because we do it on recurrent abortus samples, and blood samples. So what kind of we have never attempted.
Okay, we will take that question and address that via email at after the event. Another question is, in the SMN case you presented, why did you need to use the grandparents, and was this maternal or paternal grandparents?
Paternal side grandparents were unavailable, so I used maternal side grandmom, because grandmom was a carrier for SMN and she passed on the defective gene to her daughter. Since we do haplotyping studies and linkage as a matter of accuracy and to compare against
Okay, I think we're going to close the Q&A session, the end of that session now. And I apologize if there's any questions that we did not have time to answer. Okay? But again, I'd like to thank Dr. Ritu and the audience for their participation, as well as both Dr. Saleem and Dr. Youngjoo. Okay? So this really concludes the webinar sessions for today. Just as a reminder, the virtual conference environment will remain live and open. So please do drop by the booths, especially the reproductive health booth, where you can interact with us and find out more information about any of the reproductive health genetic solutions that we have available to help you accelerate your research. You can also participate in the scavenger hunt game. You're looking out for the icons that you will find in the conference environment and the exhibit area. Collect those icons and you stand a chance to win some prizes. Please, I also encourage you to complete the pop-up survey that will appear shortly. And again, I just would like to thank you all. Hope that you will be able to join us tomorrow for more talks on our solutions in reproductive health. So thank you everybody and stay safe.